I know everybody's name, but more and brown, more.
Also mine.
It's like not just the I know you. I just had to remember your surname. Oh, that's Oh, okay. I didn't realize that Neil wasn't there. So what happened? Should I say? She just put it.
She helped design this session.
Oh, she's just not going to be there. That slide. I'm sorry,
That's fine.
So you're right.
Anybody there? No. No, I can help. Oh, you're the solicitor?
Yes.
Oh, great. Welcome. I'm Brent.
Okay, so I'll just read those things. I know that you're the coordinator for Pathway and then
Where do you want to sit? You want to sit screens there? Sit
whatever the title of it was.
Is that all right?
Yeah.
Perfect.
I think you're true. It's time to start. Let me see it later. I'll just look at it. Okay, should we get started? Okay. Good morning, everyone. Hello. Good morning. We're going to go ahead and get started. We're a few minutes late, so I want to make sure that we end on time if there's another session in this room. So thank you all for joining us this morning. I know the paper program didn't quite give insight into what this session was, so hopefully it looks like most of you must have seen it online. So we're here. It's actually going to be a really exciting session, and it's an area of work that's very near and dear to my heart. So we're here to learn a little bit about behavioral science, some new and interesting work in terms of nudges and use of AI, artificial intelligence tools, and rapid learning, rapid assessment in thinking about this work. So I'm going to actually give a little bit of background, but I'll go ahead and run through, I think, the first couple of slides just to introduce us to the session and our panelists. Now, can somebody move to the next slide? Can we move to the next slide, please? Okay, great. So just to start us off, I'll give a very brief welcome and an introduction to, hand it over to my colleagues here for an introduction to Indlela, what Indlela is, the Behavioral Hub. We have some oversight over a recent Grand Challenge award for an AI tool. And then we'll end our session with a discussion with all of you. So I hope you can keep your questions ready for the panelists. Next slide, please. So here are my panelists. I'm Maya Sundaram. I'm a senior program officer at the Bill and Melinda Gates Foundation. And I work very closely with HE2RO on the Indlela project. We have Dino Rek, who's the CEO of a health tech company called Otteray, and is also an external advisory board member for Indlela. Caroline Gavithson, who's Indlela's behavioral economics fellowship lead and is also the country lead for Zimbabwe. Neon Lovu, who has helped organize our session but is not here on our panel. And Brendan Morn-Brown, who's the Indlela behavioral science technical expert. So a great panel and are going to be able to give you really great insight into the work of Indlela and the role of behavioral economics more broadly in the HIV space. Next slide, please. So, as we think about behavioral science, what is the role of behavioral science, and how do we think about understanding, really truly trying to understand human behavior and the factors that impact human behavior, and how we can address those factors and truly program for our clients and our patients. So including what psychosocial, economic, environment, and structural factors that they're thinking about in their everyday lives, and how do we help think about those things to program for people in the right places at the right times and for their needs. So it covers a number of different disciplines, including sociology, anthropology, ethnography, behavioral economics, which is what we're here to speak about today, among others. And we want to really think about the value and use of this science as a core tenet in the way we think about programming. So in the context of HIV, what does that actually mean for us? You know, we've made tremendous strides in the response. I think we've seen a lot of interesting work here at this conference, and a lot of that has been rooted in behavioral work. But a lot of it is also driven largely by biomedical interventions. And we've seen tremendous scale up. But how do we actually think about sustaining those things and really having the durability in those interventions for the long term and reaching the last mile, closing the gaps that we have now? And frankly, thinking about the themes of this conference, which are inequalities, accelerating inclusion and innovation. How do we think about true community leadership? I think all of this is rooted in truly understanding the populations, and not just the clients and patients we're trying to serve, but the healthcare workers, the program managers, the people who are actually driving the systems are critical to those systems. So organizations like mine, like the Gates Foundation and PEPFAR, and other large funders recognize the value of behavioral science, behavioral economics, and we're trying to make more and more investments, building on some of the successes we've seen in the past, such as condom social marketing programs, you know, and others that have truly had large scale social behavior change components and have been tremendously successful. How do we leverage those successes and do more, leveraging private sector capabilities, new innovations and technologies, including artificial intelligence, which is very new on the field, to meet these goals that I outlined. So with that, I'm going to hand it over to Brendan to take us through an introduction to this session. Thanks.
Thank you, Maya. My name is Brendan Morn-Brown. I'm from the University of Cape Town and a proud member of the Indlela team. Indlela means the path or the way in Zulu. We recognize that there are many different paths that people may take towards a goal, but also that along the way, there are many potential speed bumps, barriers, boom gates that they may face and stand in their way. Indlela focuses on the use of behavioral economics to design interventions that aim to smooth out some of those speed bumps, to lift those booms, and to help people along their journey. We recognize that we've made huge progress towards many of the key HIV prevention and treatment goals. We're actually quite close to many of them, but now we need to focus on encouraging very specific behaviors in order to get us across the finishing line. Indlela's mission involves building an evidence base of what works by designing and testing nudges and behavioral solutions which aim to increase the effectiveness of health services and to achieve better health. We also aim to build capacity in the understanding of behavioral economics and how it can be used in interventions and programs. And we do this with a range of stakeholders, community members, researchers, beneficiaries of programs, among other things. In the last few years, we focused on establishing Indlela in South Africa. We're now looking to the next several years, where we're working to establish collaborations across Eastern and Southern Africa, and to leverage South-to-South learning networks to further extend and strengthening our capacity building and evidence generation activities. On the slide, you see our core Indlela team that comes from HE2RO at WITS, the University of Pennsylvania, the University of Cape Town, and Boston University. But we really are a much bigger family with a huge number of constituencies and different stakeholders from different sectors involved in the project. We are also extremely grateful for an incredible external advisory board who inspires us and guides us through the process. And this includes Dino on the panel today. We thank you for being here with us today, Dino. What we're going to do today is give you a very brief overview of some of the highlights of our work. We hope that some of these highlights might spark some ideas for your work, but also might spark ideas for how we could collaborate, and that you'll then be in touch with us and we can connect and take things further. So we've focused on building capacity in the use and understanding of behavioral economics through a variety of different fora, including workshops, webinars, and symposia. And through this process, we've developed and built a really strong family and community of practice. On the right of the screen, you'll see a QR code. If you scan that, that'll help you sign up to a WhatsApp group that we use to facilitate engagement with this group. I'll also, at the end of the session, we'll also put the slide back up. So after you hear all the work we do, you can rush up and scan the QR code. So we use the WhatsApp group to share ideas, share learning opportunities, thoughts on current debates in the field, and also importantly to hear from the community of practice about the work that we're doing and get guidance from them as well. We also use the community, the WhatsApp group, to share some of our findings, which are often shared in formats such as our behavioral insights reports and the policy briefs, which really focus on sharing the behavioral insights and the findings from what we call behavioral insights tests, in which we have designed specific interventions and then worked with partner organizations to both design and then to test them. We focus on a range of outcomes so far, from HIV testing to ART initiation, adherence, retention, re-engagement in care, the uptake of male circumcision, and beyond HIV, also looked at interventions to increase the uptake of COVID-19 vaccinations. Our community of practice has also been involved in our first Nudgeathon. We hope to have many more of these in the future, because our first Nudgeathon was a high success, and it was really exciting for us, and the outcomes were extremely positive. So let's just ground ourselves on what are nudges. So these are interventions which nudge individuals towards a specific behavior, nudging them to one of those specific paths they may take. They're generally low-cost, light-touch interventions which leverage well-known factors that influence decision and behaviors. So, for example, social norms. Like, we know that if you tell people in a town that most people are using HIV self-testing kits, that is likely to increase the use of HIV self-testing kits among the community. Make decisions and behaviors easier for people, they're more likely to be enacted. So to the Nudgeathon, so what we do is we focus on a very specific problem, say, how do we increase the number who start PrEP, who keep using PrEP? We then get an amazing group of people together and lead them through a process in which a huge range of potential barriers are identified, and then a huge number of different solutions and ideas for interventions are generated. So in our first Nudgeathon, we generated over 100 ideas for potential solutions to increase PrEP uptake and persistence. So once we generate these ideas for interventions, this may come from the Nudgeathon, may just come from the community of practice, from partners, may come from the external advisory board who've read something really awesome and say, you guys have to try this out. We then work with partner organizations to design a specific nudge, and then to evaluate it. I'm going to give you one example. In this example, we tested whether the Fresh Start effect could help promote re-engagement in HIV care in South Africa. So I think you all have heard of the Fresh Start effect. Have you ever made a New Year's resolution? Have you ever woke up on the first of the month and decided, I'm going to start training for something new? In behavioral science, that's called the Fresh Start effect. It works because a specific time point signifies the start of a new period where we can leave the past and the failures behind, and we can go forward with a clean slate. So there's many different points and times which are effective. New Year's is a big one, birthdays, anniversaries, even the start of a new week can work. So what did we do? We teamed up with Anova Health Institute, and we created Fresh Start messages, which we then sent to people's mobile phones. We included people in the study who had missed a clinic appointment for ART by more than 28 days. So what we did is we randomized some people to receive no message, and then we randomized another group to receive a message around a specific holiday. An example was Youth Day in South Africa. And the messages also emphasized the chance for a new beginning. And then we tracked people to see the proportion who started ART within 45 days or return for an ART visit at the clinic within 45 days of the intervention. All right, so what did we find? Here, we'd love to get your sense of what you think happened in this intervention. So we're going to do a poll, and we're going to do this old school. So we really want to get your perception on whether you think the Fresh Start effect worked in increasing re-engagement in HIV care. So this is how it's going to work. Keep your hands down if you do not think it had any effect. All right. So right now, none of you think this intervention worked at all. All right. So then raise one hand if you think the intervention worked, and the effect was between 1 and 5%. So one hand is 1 and 5%. And then raise two hands if you think the intervention worked and the Fresh Start helped increase engagement with care between 5% and greater. All right, 2, 1, none. Okay, brilliant. So I'm seeing a general perception that people think the intervention worked. I think a lot of more people seem to sway on the side of it increases engagement by more than 5 percentage points. All right, so let's see what actually happened. So what we did is we sent messages around Youth Day, and these results are for the individuals who were out of care for less than 6 months. And what we find is that the Fresh Start message increased the percentage who returned to the clinic within 45 days by about 3.5%, which as a nudge, which is extremely low cost, we see as a success. So now I'm going to hand over to Caroline to provide some additional examples about our work.
Thank you. Thanks so much, Brandon. And thanks everybody for being so engaged. So I am going to talk to you about one of, back. It's not working. Okay, so I'm going to talk to you about one of our innovations that we call the Indlela Behavioural Hub. And so I've been really inspired by some of the conversations that we've been having at this conference that have really emphasized the need to have the community be at the lead and their perceptions and the community be centered when we are designing and developing interventions within any context for HIV and for health in general. So what we've got is that really we need to have the community perspectives. We need to dig into the community when we're trying to find out what the challenges are for the problems that, for what we're trying to solve for health, for HIV, whatever it is. We also then need to have the community at the center when we're trying to look at the solutions, because contextually the solutions may be different. The things that people need are going to be different. So we need to really tap into the community to start thinking about the solutions. And this will help us really think about our resources and see where we need to be putting our resources, the kind of work that we need to do, the research we need to do. And we need to be very adaptive. We need to do this fast. And we need to be iteratively just learning and putting it back in and learning again. So we wanted to come up with an innovation within our work that would allow us to do this and would allow us to do it fast. We came up with the Indlela Behavioural Hub. And the Indlela Behavioural Hub really is a group of individuals. We've got health workers, we've got recipients of care, we've got community members, and we've got different key populations, MSM and many other different adolescents, different key populations within this group. Currently, we are over 800 members, the community members, health workers, community members, and recipients of care. We've got almost 100 healthcare providers. And we started this in Gauteng. We are expanding to other provinces, and hopefully we'll be able to expand to other countries. We collect on enrollment to this panel. We collect information, basic demographic information. We collect information about HIV status, HIV testing behavior, COVID-19 vaccination status, and a whole lot of other demographic information that allows us really to segment and know who we're dealing with for any given problems that we want to tackle. And a really interesting thing about this group is this panel is available to us. We have a relationship. They know the work that we're doing, and they're available to us when we need to answer a question. We just have to determine whom we need to talk to and how we need to be answering some of the questions that we have. So that's something that really works for us. So I'm going to take you through just some of the ways in which we are using this Indlela Behavioural Hub to answer some of the questions. We use a rapid survey. So with rapid surveys, we may really just want to test the waters and kind of figure out what's happening in this place, in this context, say around HIV vaccines. HIV vaccines are coming, there's a lot of work going into them, but how do people feel about vaccination in general, HIV vaccines, post-COVID, just sort of get a pulse on what's going on. So we'll do these rapid surveys with different members of the community, and this will inform either policies or, inform how we write our grants, some of the other work that we want to do. We're kind of always adapting, and we've got really fresh insights as we go into any work outside of the traditional ways of literature reviews and other ways of gathering data. We also do what we call A/B testing. And A/B testing really is where we're able to randomize people. We might have different things. We randomize and we're like, let's kind of see what the impact with a small sample size. Let's see what the impact is going to be, right? And we do some randomization there. We also just do prototyping and feedback. We'll do this with healthcare workers. We'll start developing something. It's iterative. We'll take it back to them. We'll take some things off the prototypes. We'll put some things back, and we design as we go. It could be a job aid. It could be, a material that's for literacy improvement, whatever it is. We're asking about language. We're asking about the user interface. We're asking about different things. And we're really, as we're prototyping, we're taking the community with us. We also have contextual inquiry. And like we said, when we're designing, especially behavioral design, context really matters. And so we want to get into the context. We want to see how people are using certain things, find out what they're thinking about it, see what drives their behavior. And again, this informs our research and also can be a quick way to inform policy and other things that we do. And I have to say that we have ethics approval to conduct this kind of work, to have this kind of panel. And as we bring in different behavioral insights tests, we're simply kind of going back to get ethics for that particular concept. And this has made it really fast, and we've been able to do certain work really quickly compared to the other work where we haven't had something like the Indlela Behavioural Hub. And so we're able to learn, pivot, go forward quicker than a lot of people can. I'm going to just play a quick video. It's a 2-minute video. and really just explains in, what I've been talking about in a little bit more detail. Thanks so much.
In South Africa, we launched Indlela, which means the path or the way in isiZulu. The Indlela team develops and tests behavioral solutions to challenges in health and HIV service delivery in South Africa. But what are the most pressing health challenges? And how can we know how to address them? To find out, we knew we needed the community. In South Africa, we launched Indlela, the which Indlela Behavioural Hub, or the way. We recruited 50 healthcare workers and 500 the Indlela team develops and tests and healthcare recipients in challenges in health and HIV. Our team collected socio-demographic and health information. What are the most pressing health challenges? Vaccination. And how can we know how to address them? In our work, the community is at the center. We can gain insights from the BHAB members in many ways. We recruited 50 healthcare contextual inquiry helps us understand community our end users and healthcare recipients in Johannesburg, preferences, and our team collected socio-demographic. We called BHAB members to ask what they thought about the COVID-19 booster vaccination to inform community messaging around the vaccine at the center. We can gain prototyping gathers feedback on an intervention in the design phase. For example, contextual inquiry helps us members might review 3 different brochures we designed to promote HIV testing and screening. For example, and help us refine them before testing to ask what they thought about the COVID-19 A/B testing helps compare 2 options to make community messaging around the vaccine rollout. We might test if a callback to gathers oral HIV on an intervention in the design phase. If they were called at random times, our BHAB members might review 3 different brochures we designed to promote HIV testing and screening. Rapid surveys and help gather information before testing and answer a range of research questions. A/B testing helps compare 2 options to make members about their intention to initiate PrEP. We might test if a callback to report oral HIV test results reached more people. If they were called at random times, these activities versus a chosen preferred time help center our work around the user experience. Rapid surveys can gather information, steward our resources, and answer a range of research questions. And we're not stopping there. For example, over the next 12 months, we're expanding to initiate PrEP across South Africa, reaching more diverse groups and growing our partnerships. These activities. Do you have questions about health behaviors center our work around the user experience? Learn quickly and steward our resources efficiently. And get in touch. And we're not stopping there. Powerful over the next 12 months, we're expanding BHAB membership across South Africa, reaching more diverse groups and growing our partnerships. Strong and healthy South Africa. Do you have questions about health behaviors that need rapid answers?
Thank you so much. I'm going to hand over to Dino.
Are you looking for community insights?
Really cool project.
Then get in touch. The BHAB is a powerful resource for developing user-centered solutions to persistent health challenges. We look forward to partnering with you for a strong and healthy South Africa.
We're hearing more and more about AI and its potential. But one of the key questions is, how do humans react, respond, and use AI? How comfortable are they with it? In this specific example in question, we looked at AI in the context of an HIV use case, and it's all around a conversation. So in healthcare in general, one of the biggest parts of a healthcare journey is conversation, a history that a medical professional takes, getting advice, counseling, when you've got a problem, checking in with your case manager, with someone who can help you. And when we talk about efficiencies and dwindling budgets, the question is, can large language models or AI be part of having that conversation in a responsible way? And how do people respond? So in terms of the work with the BHAB, we built a piece of technology to simulate an AI, a counseling session around assessing risk for PrEP, or personal risk and eligibility for PEP or PrEP, for PrEP specifically. So you would engage with the AI counselor. It would ask you a series of questions. You could respond to the AI counselor. And ultimately, at the end of it, it would provide a summary to the healthcare professional around this discussion that you would make a decision around. The B-Hub was important. Why? Because we needed to test this fast. We had a grant from the Grand Challenges at the Gates Foundation. We had a limited amount of time. We needed to build the technology, and we needed to get these important user insights around how people perceive this, around if it can be used, and what is the limitation of what it can do. Does the tech work, and do people accept and use the AI? So together with the Indlela team, we had this perfect combination that you can see on the slide, where Indlela would handle, and the B-Hub, some of the behavioral questions that are so important, and Outer would build and tailor the tech to the specific need. Next slide. So this was called the Your Choice project, and we had an app prototype. And what we did is created this persona, this AI persona, to engage in a non-judgmental, knowledgeable manner with the individual, assessing their risk, their interest in PrEP, and their PrEP eligibility. We assessed 3 or 4 different large language models that we built a engineering infrastructure around to use. So we looked at ChatGPT, Llama, and Claude AI. And we designed the requirements, the prompt engineering, the rules for how the conversation would proceed, and the summaries of the relevant parts of the conversation for the healthcare worker. This shows some of the flow and some of what the screens look like in terms of this back and forth. And we enrolled 100 clients and 20 healthcare professionals to use this app, to assess the usability, to see how acceptable it was, and to see the appropriateness of these conversations and where they worked and where there were potential issues or errors. An example could include something like local slang. In South Africa, STIs are often referred to as having the drop. That was something that the large language model initially didn't understand, and we had to add and tailor for local context. So as we learn more about it, and as we gain insights from testing in something like the B-Hub, we can tailor the AI to be more context specific and better. So where to next? We've begun to write up the findings of this initial stage, and we're looking forward to sharing these. But what we're seeing is the app can help us identify and connect individuals at substantial risk of HIV infection to tailored prevention strategies, including PrEP. Looking at 90% of people at risk being linked, 95% of those using prevention, and less than 10% experiencing stigma and discrimination. We feel like this is just the beginning of this aspect of behavioral science and behavioral economics when thinking about AI. And we see this as our initial foundation and stepping stone with the Indlela team, and with using something like the B-Hub to continue to iterate and continue to try out new use cases around where large language models can successfully substitute and add to a discussion with a client around their HIV journey. I think that's the last one. Thanks.
Great. Thanks to our brilliant panel. And I think,
Can I jump in for 1 second?
yeah, sorry.
Before I hand it over to
Go
the
for it.
Q&A?
Yeah.
So Indlela really grows from strength to strength by learning from the community of practice. And as we move towards the next year of our work, we really wanting to hone in on the key behaviors that if we shift either up or down by even a little bit, will have a big difference on health outcomes. So in your goodie pack that you receive coming in, there are some post-it notes. And during the Q&A, if you have any ideas around the behaviors that you think we should be generating ideas and solutions for, we would love to hear, and you can hand them to colleagues on the way out. So thanks, Maya, back to you.
No problem. Thanks. Great. So we have 12 minutes to do Q&A, and we would really love to hear from the audience. I think the team here has presented some quite groundbreaking applications, a platform that can be used, while it is based in South Africa, can be used to help inform others as well. And so we would love to hear from the audience what questions you may have for this panel. So let me open it up now and see what we have. And maybe I will start us off to get the brain flowing. So Dino, maybe I'll start with you. Given that the AI piece is extremely new for everyone in the world, and it's kind of taking us by storm and changing rapidly. What do you feel like are some of the greatest opportunities and challenges, obviously, as we think about these applications and the way in which the use of the B-Hub and the expertise we have here in Indlela can help inform those aspects as countries, program managers, and others are thinking about this for their programming as we go forward?
Thanks, Maya. So I think the great opportunities around efficiencies, when we think about our human resources, we're already constrained. We already don't have enough people to be able to provide an unrushed conversation. Time is a precious resource. So in terms of the ability to use a virtual assistant with a human to gather information from an unrushed conversation and provide it to the human, to then still engage the patient, I think is important. And what I'm talking about is humans are still involved. We don't believe at this stage that AI should be running by itself. We think that AI is an important tool in having an unrushed conversation, gathering valuable information and making that patient feel heard, but still linking that back to a healthcare provider to follow up. I think where we're cautious, and I see a hand, where we're cautious is really related to what is that limit? How far can the AI go? What is the human comfortable with? And the behavioral side of how that interaction happens is where a team like Indlela is so important.
Great, thank you. I think we had a question. Oh, you have, okay. Here. That's okay. Here you go.
All right, thank you so much. Thank you so much for the beautiful presentation. My name is Dr. Khaone Magwinja. I'm from Botswana. I work for a local NGO there called Behavioural. My question is, with the use of the AI, believe, or we believe that it's using technology in terms of resources, that is phones, tablets, and in our landscape, it's not everybody who has access to those resources. Are you not concerned about the biasness of the data that you get there? Because it could only be people that actually has access to these resources that actually respond to these questions. I hope I'm clear. But yeah, thanks.
No, I think it's a really important question, and especially as we're thinking about these tools having been developed largely in Western countries. So not only those that don't have access to some of the technologies, but aren't necessarily from the same geographies. How do we think about training them properly? I'm guessing that's a Dino question.
So I think there's two parts. I think what we do at the B-Hub is around the bias of where they were originally designed. So something like not knowing what the drop is, or local terminology, or local context. We as an engineering team work with the feedback we get to train it to be more context specific. On your question around technology resource allocations, whether it's smartphones or connectivity, it's an excellent point. It's one that I think we're concerned about. I think the hope is that smartphone coverage, we're talking about very basic entry-level phones that cost $20 that have WhatsApp functionality. That's all you need. So these are we're not talking about Apples or Samsungs, like the very basic that you can buy at a market in Lusaka or in Chinatown in Joburg. But yes, feature phones are still very prominent. One idea is to use voice to language and language to voice. So you would be able to phone in and actually have a conversation from a feature phone with an LLM, have that conversation via voice, in fact. And we think that functionality can be built into even benefiting feature phones. So it wouldn't be texting back and forth via WhatsApp, but your feature phone would phone into like a link, the LLM would introduce itself, and you'd have a voice conversation with an AI counselor, and it would summarize that conversation in the same way as I described. So great point. I think a lot of us are concerned about it. It has to be front of mind, and we're doing our best to think through those.
Okay, so just to quickly add to that as well, I think in the next part of the work that we are doing, we're going to be having conversations with policy makers, healthcare providers, really getting all the stakeholders and designing not just the intervention of the app, but the ecosystem around which this app is going to be working. If it could be something in a clinic and somebody has a booth and you get into a clinic and there's a phone there. So I think we have to think big. We have to think together about how to solve some of these problems.
I'm just going to take my moderator privilege and add something to this, which is, I think the other thing from a behavioral science perspective is we need to think about humans aren't a monolith of people, and certain channels of communication and design of interventions is going to be segment specific. And so while we recognize that this app is relevant perhaps for certain people in certain populations, it is not actually intended for everyone. And there are going to be other channels of communication, of delivery of services, and we need to be really thoughtful. And the intention of using the behavioral insights and behavioral science to drive our work is to have that differentiated, targeted approach. I know we had a question in the back, but actually there was the gentleman up here had the question, I think, first.
Thank you so much. This has been very enlightening. My name is Francis from Uganda. I would have loved to hear a little bit more from the community perspective, those who participated, on what their concerns are and the challenges, because I'm sure if you were to bring this, I would initially hesitate to get involved. Would like to hear those perspectives and what their issues may have been. Thank you.
Should I direct it to you? Okay.
So that's a great question. I'm going to speak about the AI project and the community with respect to that. I think what we have learned is that the community surprises you, firstly. So they're willing to adapt and adopt things that sometimes you don't even know. And some of the challenges that they face within healthcare facilities, some of the conversations they want to have, this was something that was more welcome than we thought. And we've got some really good insights. We're writing everything up. And the challenges that we did find, we're now putting into the next phase of this grant. That's things like text to language that Dino was talking about, that if I can't type, how do I talk to this? Because we didn't have it before. So it's iteration and building on what we're learning. And it's quite positive so far.
So I think we have time maybe for two more. I think there was someone in the back, and then on this side. Oh, is it working? I don't know. Sometimes they
Hi, good afternoon. Good morning. Mary Latka from USAID. Fantastic panel. Love the work that Indlela is doing. Thank you for all your work. So I'm at USAID, and all of my money needs to be focused on adolescent girls and young women. And we're working on developing new microbicide methods for them. But what I want to talk about is men. And we know that men have traditionally been very, very challenging to access and to get into traditional healthcare settings. And we also know men are the source of infections in adolescent girls and young women. And so 2 questions. Have you seen any effects by gender or gender differentials in the work that you're doing? And then also, I would love to hear your thoughts about how these technologies might be able to be that last mile nudge for men who have, over the last 30 years, been really challenging to engage in the HIV conversation and prevention. Thank you.
Great. A really important question. Do you want to take it, Brendan? Just because others will take it.
Thank you so much for the great question. So I agree that we have to work harder to provide access to men. One of the studies we've done is looking at demand creation using the Moya app, which is a data-free app, to try and different forms for creating interest in medical male circumcision, trying different behavioral insights and principles within those, to see how we can leverage technologies such as that to reach men more broadly. I think the question around disaggregated data is an exceptionally important one. Quite often the work that we do to make the tests very rapid and cheap, we often use administrative data, so we don't always have the access to the data to disaggregate by gender. But I agree it's a really, really important point. But I do think many of our results are pointing to the fact, just like everyone else, men have these tendencies which tend to affect their choices and behaviors, and we can leverage those to help improve their health and well-being.
Great, thank you. And then I saw there was some. Oh, okay.
Yeah, thank you very much for the presentations. So just some clarity on the B-Hub and how do you keep it fresh in terms of the participants? Is it the same people getting the questions? How do we ensure that we are not creating a